Okay. If I could call the meeting to order, we are 2 o'clock. So I'd like to advise that this meeting will be webcast live and archived for 12 months. It can be viewed at the following link that can be found on the county website, and I welcome any of those people to the Health and Care Overview and Scrutiny Committee today, Wednesday the 17th of July 2024. So welcome. Just as a form of introduction, I am Councillor Richard Cox, currently the Vice Chairman of the Health Care and Overview and Scrutiny Committee, in the elevation of Councillor Jeremy Pert, who has been moved to the Cabinet for Health and Care. If I can go straight to the agenda, please. Apologies.
Good afternoon, Chairman. I've received apologies from Councillors Jason Jones, Bernard Peters, Chris Bain and Leona Long.
Councillor Norman?
It's only for being apologies for Leona Leung, who's a new mother. Wait, did you read it out?
He did.
I'll get my ears fixed next week, sorry.
Thanks for your diligence. So moving on to item 2, declarations of interest. Do we have any?
Thank you, Chairman. Just to say, I'm partner governor from the County Council on the Midland Partnership Foundation Trust, so I declare an interest.
Thank you very much. And it's something I always say, that as the meeting proceeds and suddenly they might think, oh, actually, there is an item of interest, please indicate and we can note it. But we'll move on to our next item, which is the minutes of the meeting held on the 18th of March 2024. Seems quite a long time ago. I'm hoping that you can agree that it's a true and accurate record of that meeting. Could I see approval? Thank you, Councillor Atkins, and thank you, Janice Sylvester Hall. So I'll sign those in due course. Thank you. So we now move on to the crux of our meeting in terms of the items on the agenda. So item 4 is the Staffordshire and Stoke-on-Trent ICB, the performance overview. And I believe, Phil Smith, you're going to lead on this one. So over to
Thank you.
Thank you.
So I'm Phil Smith, Chief Delivery Officer for the NHS Integrated Care Board in Staffordshire and Stoke-on-Trent, and I'll take this item. So within the papers that we've provided, I think it's on pages 11 to 20 of the pack, we've shared our latest integrated performance report, which was considered at our June public board. The report sets out our position against key performance indicators, which are both national and locally determined in line with our priorities. As colleagues may be aware, we take a portfolio approach to our work in the system, and all of our portfolios include local authority, health and other partners in terms of plans and strategies to ensure alignment, essentially. At this point of the year, just a note before I go on, we don't have a formal financial update because it's quite early in the financial year, although Paul Brown, our Chief Finance Officer, will pick up the operating plan under the next agenda item and will take us through the detail of the financial challenge that we face as a system. I'll draw out some of the key areas from the report, and then obviously happy to take any questions. So firstly, in terms of urgent and emergency care, capacity and flow have remained challenging for us, but we have seen some improvements, particularly in terms of Category 2 response times, for ambulances, which is a key metric that we're measured against nationally, and obviously is a very important metric in terms of ensuring that ambulances are able to get to those who need care the greatest. So we're currently just a few seconds over 30 minutes in terms of that average response time year to date, and the national standard is 30 minutes. That's improved from 40 minutes last year and over an hour the year before in total. We've also seen improvement in 4-hour wait to be seen performance across our emergency portals. It's around a 6% improvement since last year, but we're still only in a position where around 70 or 71% of people are seen within the 4-hour target. In terms of challenges, industrial action has certainly played a part in making life a bit more challenging for us of late, impacting both urgent and emergency care and planned care delivery. We've also, in the last 3 or 4 weeks, particularly seen a significant spike in COVID, and I'm sure colleagues will have seen the masks, etc., are back in force now at our local hospitals. We have some new capacity coming online during August at the Royal Stoke Hospital, which will provide an additional 30 general and acute beds and also provide a new same-day emergency care facility, which we envisage will put us in a much better position in terms of both capacity and flow heading into winter. From a planned care perspective, there's been a great deal of investment to support us meeting our targets for reducing the backlog of patients waiting for treatment, also for diagnostics and for cancer delivery. By September, we're required through the National Planning Guidance to have no patients waiting 65 weeks or longer for their treatment. We do now have capacity identified to deliver that. The risks really are around pace of mobilisation, utilisation of that capacity, patient choice. So that is a big challenge for us, but certainly we've got the capacity there now. Similarly, in terms of diagnostics, it's been a very challenged area, and with the exception of non-obstetric ultrasound, we're now expecting to have sufficient capacity in place to meet the demand that we have for this year. From a cancer perspective, I'm pleased to report that our backlogs of patients waiting for treatment against what we call the 62-day standard is now in what we would call a sustainable position in terms of being able to deliver cancer targets. And as such, we're now seeing improvements in our 62-day treatment standard and the 28-day faster diagnosis standard. Just pick up a few other points. In primary care, we've seen a 10% increase in appointments over the last year, although we recognise there are still concerns in this space. An access plan was approved by our board in May, and I believe there's a further session in September time for Overview and Scrutiny Committee to consider primary care in detail. From a dental perspective, we have seen an increase in activity but remain behind plan. There's a dental strategy in development to support oral health access, activity and workforce. Lastly, from a mental health perspective, we've seen dementia diagnosis rates higher than the national position and above expectations. Talking therapies are behind plan, but there is capacity, so we would encourage people to access that. Access can be either via GP or self-referral. From an autism perspective, we know that we continue to have high waits for assessment. We do have investment going in, but there is a real challenge, as there is nationally, in terms of workforce in this space. So we're seeking to access more NICE approved independent sector capacity. I'll pause there. I'm conscious there's an awful lot of detail in the report provided. I've tried to give a bit of a flavour, but then happy to take any questions or observations. Thank you.
Okay. Charlotte.
Thank you. I'd like to pick up on a few of those points. I mean, why is it that autism waits are not only bad, but they're getting worse? It just seems amazing to me when the impact on largely children or young people is so devastating. I mean, why isn't resource going into that to resolve that? This is not a new problem. It's been around for a very long time. That's the first question. The second question is about dental issues. You've had responsibility for dentistry for now well over a year, and you're talking only now about your dental strategy. You seem to be putting some credence on the idea that the new patient premium will resolve problems. Well, it won't resolve problems because it won't increase the number of dentists. So what are you doing about the NHS dental, the dental deserts, which exist all over this area? What are you doing to ensure that people have access to an affordable dental service? Because at the moment, many people just don't. And they can't very often jump in a car and go, you know, several hours to an NHS dentist. And nor do they feel that they can go to a private dentist when they really are at the mercy of the private practitioner about how much they're going to be charged. Because they don't know when they sit in that chair what the overall bill is going to be. So those are the two issues. I think the third issue I'd like to raise is you talk on page 19 about your surge update, and you plan to start de-escalating community capacity, and that's beginning to happen now. Why is that happening now when we're going to be heading into winter, when we'll need that extra community capacity? Thank you.
Thank you for the questions. So certainly in terms of autism weights, as you say, it is a significant challenge for us and is a challenge nationally. There is investment going in. I don't know if you've got any detail around that, but that you can provide, but significant challenge around workforce as well. So I think it's probably best if we commit to providing a written update in terms of the plan around autism for you, just so that we do it full service, unless there's anything you want to add.
I haven't got the numbers in front of me, but we are investing in autism, as Phil says. We can provide those numbers. So yeah, it's a service, as you all know, with significantly increased demand, which we're trying to respond to. But the demand is very, very sharp. But we are putting more money in, and we can obviously come back to you with the precise numbers.
Chair, if I could just quickly come back on that. I mean, the problem is that parents in desperation then end up going to so-called independent practitioners, coming up with a piece of paper which is not worth the paper it's written on, saying, my child has got autism, therefore I need an EHCP in school. And they are being fleeced by independent practitioners who are giving them the hope that that piece of paper will actually be some sort of magic carpet to give them an EHCP. And, that is the problem. People are being exploited because there is a need, because they feel that they need to be pushing the special educational need button.
Yeah. Okay, thank you. So, as I say, we'll get a written update around that. In terms of dental, so from a West Midlands perspective, there is now a dental strategy in place. Locally, we've done an equity audit to understand the local need and variation, but that plan is in development to be launched in the autumn. So again, happy to provide a written update around the plans for dental, unless colleagues want to add anything.
So have you established the dental deserts, the NHS dental deserts? Do you have that information?
So when you mean dental deserts, you mean what exactly?
I mean where there is no local dentist that is providing any NHS service to the local population. That's what I mean by an NHS dental desert.
Yeah. So we have those areas across the patch. You're quite right. We are sited on them, absolutely. So as you'd expect, we know where the dental provision is and where it isn't. It's a tricky one. This is one where we're genuinely trying to spend more money, and we can't at the moment because dentists are not taking up the contracts. So I don't want to deflect blame, but it needs that sort of national approach to the contracts of dentistry. We locally are working to obviously encourage as many dentists as possible to come into practice and take on NHS patients. That's what we're trying to do, and we're trying to, as I say, spend money that we haven't been able to spend in the past. Yeah, absolutely. We're cited on where there are gaps in provision across the patch. And again, if you want to see that information, we're very, very happy to provide it.
Thank you. And just in terms of the final point around surge capacity, we have a capacity model for the system, and the capacity that we have online is aligned to that. Essentially, the demand flow of the year is well, if you say start from September, there's a very steep rise in terms of demand from September through to December, and then a very, very slow sort of trickle down of demand right the way through to July, and August is generally the only month of the year where you're not in some form of surge, if you like. So what we work to do is align our capacity to that. We've been set the mandate nationally that we cannot reduce general and acute beds, so acute bed base, but other bits do sort of increase and decrease at different points of the year, such as primary care, winter hub access that we capacity that we have in place, additional discharge to assess beds, and other supporting schemes that wrap around. So essentially what we're trying to do now, as you'll hear later on down the agenda, is take an annualised view to surge and make sure we're just aligning the capacity to where the demand hits. The challenge for us is being able to predict the spikes that happen. So, for example, COVID spiking very seriously over the last 2 or 3 weeks has been a real challenge, and therefore being able to mobilise capacity to meet that demand is difficult. So the point of improvement, if you like, is being able to identify those surges as they start to make sure we can put things in a timely way.
So why are you de-escalating community provision?
So community provision was fully in place up to the end of April. So we saw through the Easter period, and then the demand essentially reduces as you head through into the summer. So we don't turn it off, we sort of dial it down, if you like, and then we dial it back up again as we head towards September and October. So the principle is that it's aligned to the shape of the demand curve that we see, and certainly for example, from a hospital discharge point of view, we're seeing very strong flow out of hospital. We're certainly not seeing those discharge services struggling against the current capacity, but we keep a close eye on it to ensure that we remain in that position. It's just about making sure we've got the right capacity to meet the demand at key points of the year. And like I say, when I go into the surge report and winter learning, I can pick up a bit more on that. Thank you.
Okay, I think I'll move on there to Councillor Janice Sylvester-Hall.
Yeah, thank you very much, Chair. A couple of my points have already been covered by Councillor Atkins, and I found that that diagram where we can see the mitigations identified but unlikely to improve, sort of focusing attention onto autism and the dental activity. The only thing that I would like to add at this point to the autism side, and I eagerly await more information from those, is that it's actually all ages. And I think there was a focus there on younger people and the route into potentially getting their EHCP. But it is all ages, and in particular, I believe it's still the case that women tend not to be diagnosed with autism until adulthood. So it's the scope of that I would like to make sure that is being covered, not just the focus on the younger generation. But just to cover another couple of points that haven't already been mentioned, with regards to the capacity, you informed us that there's an extra 30 beds that are going to be available. How long will it actually take to get those 30 beds filled, I think is going to be my first initial question on that one. And then the second one, if I may, at this point, underneath the category for the planned care, diagnostics and cancer, we've also got a couple of red items in those. And if there's some more information, I might have missed it in what you said at the beginning. There was a lot of information there that we went through with regards to the trajectory for eliminating the 65-week weights delivered. If you could just give us some more information on those, please.
Okay. Thank you for the questions, and absolutely we'll ensure that the autism update we provide covers all ages. In terms of the additional capacity that's coming online, what you often see in systems is you bring beds online, they fill up, and then you're in the same mess again. So the key is here is to make sure that our flow is right, that our length of stay is right, and that we're only admitting those patients who absolutely need to be admitted, which is why the almost the more valuable part of this equation is the same-day emergency care facility, which will go live at the same time, because that will ensure that people can be brought in, have access to all of the benefits of hospital care, diagnostics, etc., but for that shorter period of time to enable them to go back home again, rather than getting admitted into what we call the deep bed base. Certainly the modelling that we've got suggests that these 30 beds that are coming online are needed in order for us to deliver safe levels of capacity as we head forward. And certainly if you look at the modelling in a crude state, because of the changes in demographics and demand, essentially every year now, exponentially, you could be in a position where you've got to build another 30 beds. Clearly, when we come on to finances and things like that, and what's best for the population, that's not going to be possible. So we have to take a different approach to that and not just keep exponentially building capacity. Lastly, in terms of 65-week waits, it's certainly a big challenge for us. What I would say is we've come a long way. So this time last year, if I was sat here, we'd have over 37,000 people waiting for over 65 weeks for treatment. This time this year for our whole population, so that's not just those who are at university hospitals in North Midlands, that's for our people who access all hospitals. That figure's around 1,600 as at today. So we have seen a massive improvement there. We've got a real push now to get to that finish line for September, but it is a challenge, absolutely, and the challenging specialties specifically are respiratory and gastro, which are the ones we're just working to try and make sure we can get all of the capacity mobilised in a timely way. Obviously, the bigger prize here ultimately is getting back to a position where the 18-week standard is met, and that's a position that we've not been in for many years now, unfortunately. But there are key milestones along the way, and certainly the next one after getting to 65 weeks is getting back to 52 weeks, and then working our way down from there. I hope that helps. Thank you.
Councillor Norman.
Thank you, Chair, and welcome to that chair, and also congratulations to your predecessor as Cabinet member now, and I wish him well. The thing about overviewing scrutiny is that you're always looking at the problems, not really saying so much about the successes. So forgive me if I do concentrate on that, and particularly the RAG ratings that you've got on your achievements so far. One is the planned care, diagnostic, and the urgent and emergency care. I mean, when it takes 6 hours to get an ambulance, it's well, you would never have believed that a few years ago. And I realise there's been problems and pressures from COVID, but it is something that must take a priority now. I'm particularly interested, though, in the autism diagnosis and that. Two questions. I'm chair of governors I've been chair of governors for 20 years at a special school, and the children we have now got increased complex needs in autism and so on, and we haven't got the capacity. We keep getting pressure from the county on finding places, and they are doing some things there. But can you tell me if the figures for children with autism are higher in Staffordshire than anywhere else? I'm not talking about how well you're doing the diagnosis, but are there any figures that show that we're above average nationally or not? I just don't know. I don't know where to look. And that is one where we've discussed this this afternoon, and wish you well on that one. Okay. Thanks, Chair.
Thank you. If I pick up the second one first, I'm not aware, at least I don't have to hand any figures in terms of that comparison, but certainly when we provide that written update looking at all ages in terms of autism, we'll make sure that we provide any context we can in terms of where we sit nationally, because I think that's a really important point. I've not got the figures down unless colleagues have. Just in terms of ambulances, absolutely, and it's a multifaceted problem, really, in terms of ambulance response times and flow in our system. Everybody has a part to play in terms of it. So, as I said in the opening section, we have seen significant improvement in ambulance response times, because the greatest risk is always the patient who's lying on the floor at home and no one's been able to get to them. Once a patient's within our hospital settings, etc., there's obviously sort of wraparound care that's there. So we always recognise that those are our riskiest patients. So we are, as I say, year to date, meeting that national standard in terms of response times. How that's been achieved is through a number of ways. So firstly, the West Midlands Ambulance Service have actually put additional vehicles on the road from April onwards, and this is following a CQC Regulation 12 notice, I believe it's called, that they received in February time, which was pointing out the response times across all of the geography that they serve. So obviously that's across the whole of the West Midlands. So they've certainly taken steps to do that and put more vehicles on the road for us. From our point of view within the local system, we're developing a single point of access and a true single point of access for care professionals to access, including the ambulance service, to support navigation of patients so that not all have to be conveyed to hospital. We can try and treat in more suitable settings, enhancing community response attached to that, and then ultimately when patients are conveyed to hospital, working to reduce the length of time that ambulances are spending on the tarmac, because we know that has been a significant challenge for us. Part of that is down to the internal flow and processes within the hospital. Part of that is linked to the capacity I've just talked about. And then, as I said, part of it's linked to making sure we've got the right patients being conveyed to hospital, and all of the work we need to do with community teams, with care homes, etc., to ensure only those who need to be conveyed are. So it is a challenge for us, a continuing challenge, but we are in a better position than we have been for a number of years. I hope that helps. Thank you.
I need to come back on what you may say is an unfair question, in which case don't answer it, which is if someone has a heart attack and they say 40, how long should they wait for an ambulance? Or should they be told, as has been the case in my area locally recently, best to drive in with the person? And that's more than once that's happened. If it's unfair on you, that question, don't.
Yeah, no, so I won't be able to discuss specific conditions. What I would say is that Category 1 ambulance response times are very strong, so those are the very sort of highest acuity, and then the Category 2, as I say, is within that 30-minute mark currently. So we have absolutely seen improvement in that space, and we need to ensure, again, through the right navigation of patients, that ambulance capacity that we have, which has increased, which, as I say, is a positive thing, is available to get to those who need. Thank you.
Yeah, and we can confirm, obviously, we're Councillor Norman, we will be hearing from West Midland Ambulance Services on our work programme, so we can perhaps just revisit that when we come to our work programme. Councillor Julia Jessel.
Thank you very much, Chairman, and thank you very much for this report. Councillor Norman makes a very valid point in the fact if you're not careful, you just concentrate on the problem areas. But I think one of the things that it would be negligent of me not to mention is the fact that discharges and the system and partnership working that the county has with MPFT is working very well, and progress is being made to increase the proportion of patients who need complex discharges and achieving your target for Pathway Zero. So I think we're quite exceptional in this part of the country in the fact that we have got a system that works well, because if it doesn't, then hospitals just become gridlocked. So the discharges are as important as the admissions, because you can't have one without the other. So I think in terms of the positives, it would be remiss of me not to say that. One slight criticism I do have of the report is that obviously the report very much focuses on the University Hospital North Midlands, which serves the north of the county, but the rest of us who live in the south-east, south-west, east of Staffordshire don't go anywhere near the hospital in Stoke apart from trauma cases. So I think this report actually is only relevant for part of Staffordshire and Stoke. And whilst reference has been made to the overall long-term backlog figures, I think it is something that is missing of this report, because in my part of the world, you go Burton and Derby, there are those who go to Shropshire hospitals, Good Hope in Birmingham, etc., etc. So I think because of our geography, because we're served by at least half a dozen acute trusts, I think this report doesn't give the whole picture, and I think that is perhaps regrettable. One of the questions I would like to ask is, I am aware that there is still an issue of people who get operations cancelled. You know, as councillors, we often get complaints from people about this, because often somebody who's had a date for an operation, it's not just them in their little bubble. I know 2 particular cases where people have to arrange for additional carers to come in because they're carers themselves. They've had to make arrangements for their dogs and all sorts of things. And then in the last few hours, they get their operation cancelled. And this can be repeated. Now, I know certainly from my NHS days, which are quite a long time ago, that opera cancellations were reported, and I'm sure the data is there, because that is really important. It's quite distressing for people to get themselves all organised. There's the psychological, getting yourself wound up, and then it's like somebody putting a pin in your bubble. And I understand the operational issues, but I think it's something that we do need to know to what extent this is an issue, and not only the first cancellation, second, and hopefully there's no thirds. I know there was a purge years ago to make sure nobody had an operation cancelled 3 times. But I think that is an important issue that we should have some information on. And also, in my ignorance, when you talk about the numbers waiting, the backlog numbers, does that include those people who have been given a date but their procedure not yet carried out? I.e., if you're given a date, are you taken off the backlog data? Or are you only taken off the backlog data when you've actually had your procedure done? Thank you, Chairman.
Okay. Thank you for the questions. And thank you for the kind comments around discharges, because absolutely it's nationally recognised that this system works exceptionally well in a partnership way around discharge between NHS, local authority, the voluntary sector, other agencies. I'll come on in a bit to talk about the amazing work the staff's fire and rescue have done for us over winter to support around discharges as well, which is really, really valuable. So thank you. And again, if I was sat here probably 7 or 8 years ago, I'd be saying we've got about 200 to 250 people in hospital and we can't get them out at the moment. Whereas I can now confidently sit here and say the vast majority of those discharges get out either same day or next day now, and we have sort of a 2 to 3 day maximum tolerance there once people are medically fit. And that's better for the patient, because, as we know, the longer people are spending in hospital away from the environment, they can decondition and sort of lose touch with their sort of home life. Certainly take back the point around the whole population focus to ensure that's clearer there. And just in terms of some of the numbers I've talked about, when I talk about ambulance response times, I'm talking about the whole population. When I'm talking about backlogs for treatment, I'm talking about the whole population. I think that the challenge, and probably why our report comes across a certain way sometimes, is through the NHS architecture, we're held to account for University Hospital North Midlands through the kind of NHS route, if you like, but as an integrated care board, we have responsibility for the entire population. And you're absolutely right, depending what you look at, somewhere between 50 and 60% of our population use University Hospitals in North Midlands, about 20% use Burton Derby direction, about 10% use Royal Wolverhampton, and then others are sort of scattered around Good Hope, Walsall and around there. So we'll take that point back in terms of making sure that the report is reflective there. Cancellations, absolutely, and very personal experience in terms of being in this position as well. What we're trying to do through our planning now is carve out capacity so that we've got suitable capacity for surge, where we have surge of emergency cases, But then we've got suitable capacity ring-fenced, if you like, to be able to manage elective care to reduce the risk of cancellation there. But it is something that's absolutely tracked. The other risk as well, particularly when we've been in periods of industrial action, is that cases won't actually get booked in the first place, so we can still end up sort of elongating people's waits as well. So it's as important to look at booking rates as well as cancellations. And then, yeah, in terms of the last point around the backlogs, where I talk about the 1,600, that's a position as at the end of June for our whole population. If someone was then treated on the 1st of July, they'd come off that figure. But that is a live sort of position in terms of people waiting. And just to give you some context, if we were to throw down all the doors everywhere, independent sector across our NHS trusts, right now today, there would be in the region of 6,000 people who'd be waiting over 65 weeks by the end of September. So therefore that position where I talk about 1,600, that's a position as at a point in time. There's people being treated who come off that. There's others whose waiting time increases and tips over that. So we have an understanding of the total cohort, if you like, of people to treat within that timescale. I hope that helps.
I do apologise. There was one other point that I just wanted to raise, which you may not know the answer, but obviously you can get back to us. Is that you often hear of people, their discharge being delayed, or they're spending a whole day in the discharge lounge because they're waiting for prescriptions. I can see people nodding. The TTO's been done, but the prescription isn't forthcoming. I often think there's got to be a better way of doing that. I know the idea was always to get your prescriptions done the day before, so that first thing in the morning you go to the discharge lounge, you've got your packet of box of prescription, and out you go. There never seems to be a solution to that, but I'm sure there is one. You know, is something being done about that? Because A, it does mean discharge lounges at certain times of the day are absolutely heaving, and people spend hours, frustratingly, just waiting for a prescription. And they almost feel as though, give me the piece of paper and I'll go to the local pharmacist on the way home.
Thank you. And it's a very important point, because one of the key things that we're trying to do is improve the timeliness of discharge during the day, not only from the experience of that patient who's sat there thinking, well, I'm just waiting for a prescription, why can't I go home? Or I'm sat waiting for transport, or whatever it is. But also, if you think you've got new demand coming in through the front door who needs to get through to some of the beds, so therefore it's important you've always got that flow working really well. And if all of your discharges is tilted towards the end of the day, then you can end up with a sort of a log jam in the middle of the day where you've got today's work come in, but you've not had yesterday's work go out. So we've established an integrated discharge hub, which is based within the hospital, but has sort of reaches out from there. And we've got additional discharge facilitators who essentially their role within that team is to be chasing down things that are needed, be it TTOs, be it prescriptions, be it booking transport, to make sure that we can improve that timeliness of discharge during the day. But it's still something that we need to work on, and it's something when I chair system calls on a daily basis, I'm always pushing at, have we got patients lined up to move first thing in the morning? We should know tomorrow's discharges today. We need to make sure everything's lined up to get people going. So it's an ongoing thing, but certainly it's something we are focused on. Thank you.
Councillor Anne Edgeler.
Yeah. Thank you, Chairman, and thank you for the report. My question really relates to A&E, and I know that in the last few weeks that UH&M have been in crisis with their A&E. What is being done to address this, and how can we, you know, hopefully, as we're leading into winter, but we're not there yet, we can, you know, sort that problem out. I understand that appointments to doctors are improving, but what can we do about people that cancel their appointments or just don't turn up? Because that adds to the problem of people being able to get doctor's access. Thank you. And my questions I wanted about autism and that, and dentists have been asked, so I won't follow that through. Thank you.
Okay, thank you. Yes, and absolutely. In recent weeks, we've been under significant pressure with University Hospitals of North Midlands declaring critical incident last week. And I think over the last 8 to 9 months, we've had a number of critical incident periods. What we've tried to do is learn from them in terms of what the triggers were that led us into there. Often you can see a pattern in terms of if you've had very low discharges for a period of time, then you've got a full hospital and you struggle to take in new demand. Other times, as was the case last week, we had a significant spike in terms of acuity, some of it linked to COVID, but other conditions as well, which put us in a very suddenly pressurised position. So we're doing a piece of work to look across all of the critical incidents that we've had to try and identify the themes. But I think what that will come out with is that we need to get better at predicting and looking at the warning signs to be able to deal with things before they escalate to a position of crisis. So that's absolutely something that we're focused on, and we'll be talking at our board tomorrow about that. In terms of sort of what we call do not attends, people not arriving for their appointments. We're doing all of the things that you'd expect in terms of text message reminders, etc., and also other things through the comms route around the sort of lost value in terms of those appointments. But it is a stubborn thing, really. We seem to have a percentage of people who will just not turn up for appointments. So again, we probably need to do more to try and understand the reasons behind that. I don't know, Tracy, if you've got any view on that from a comms perspective.
It's a continual problem, and you know we would look to you to help support us with that messaging as well. I mean, you'll see it in GP practices about the number of do not attends usually are flashed across a screen, and we do try to make it known, because it's not just the impact on how the running of the day is, but it's the impact on other people who may not have been able to get appointments, and then people don't turn up. So it's a big plea from us, and we'll continue with engagement with our communities on that. But you know, if there's people listening today, you know, that's the message we need to spread. We need to utilise the capacity that's there. We realise things are pressurised, but people not turning up, that's been planned for. It becomes a bit of a waste.
Thank you, Tracy. Can we move on to John, please?
Thank you, Chair. Actually, most of the points I was going to make have been covered by the last couple of speakers. But I'll start off with a little bit of praise, actually. I had occasion to go to AEC last Friday, that's ambulatory emergency care, for those that don't know, with a relative, as a referral from a GP. And the lady was seen, assessed, scanned, and on her way home with a care plan in just over 5 hours. And I thought that was pretty good. But then I thought about it a bit more, and I thought, well, 15 years ago, I'd have thought 5 hours was pretty bad. So it just shows our expectations have lowered a bit. But it was a good story, and I just wanted to pass that on to you, because it is a bit of a win. Just on the discharged drugs, it isn't the discharged prescription, is it? It's the discharged drugs. If they could be given just a prescription, they could call on the way home and pick them up. But you've got to wait for the hospital pharmacy. So, you know, I'm hoping that's been addressed. I'm not going to quiz you about the ambulance service. We're going to have them in September. But I just must say, if you think the ambulance service is hitting its targets at 31 minutes, then you're sadly out of touch with what's going on in the real world. I'd be more interested in, I'm not interested in averages. I'm more interested in what's going on in the rural areas. Because if you're only just hitting the targets on average, then it means the rural areas are still waiting a long time. And I could give you anecdotal evidence still coming in, as recently as yesterday, of people having MIs, that's heart attack, being told by the call taker, can you take them up yourself because you're going to wait a long time for an ambulance? And that's just not right. But as I say, that's not directly your bailiwick, so I'll save that for WMAS when they come. So that's all I wanted to say, Chair. Thank you very much.
Thank you, John. And obviously we'll have that debate going forward.
Yeah, is it okay? Sorry, is it all right if I just respond just on one point there, just briefly, just in terms of that rurality piece, because it is a very, very important piece, and you're absolutely right. When I talk an average of 30 minutes, we've got vastly different geographies. But the most recent week, the range, if you like, and that's probably a better way to talk about this, was 23 minutes up to 36 minutes in terms of that category 2 response time. But I'll take that away in terms of how we use our reports, because I think that reflection and drill down across the different areas is important.
Yeah, I can give you an example that happened last Friday night. Not in the rural area, it was actually in Trentham. A colleague of mine, an ex-paramedic, retired, was there for a reunion of some sort. A chap had a massive MI, and he actually arrested. Landlady called the ambulance. They're going to be a while. You know, is the patient breathing? All that sort of stuff. No, he's not. He stopped breathing. His heart stopped. It was then the intervention of that retired paramedic who did CPR straight away that got him into any semblance of order so that he could go to the hospital. And he still waited over an hour for an ambulance for an MI. And it's wrong. It's just, and that's Trentham. That's only like 2 miles down the road from the hospital. God help you if you're in Lipston's or Flash or Longner. You know, it's broken big time, the ambulance services. They need a drastic change of policy. As I say, that's not directly your bailiwick. It's an issue for them. But I'll certainly be quizzing them when they get here. But there you go. It's not fixed. It's not even close to fixed.
Okay, John. I think we'll leave that for the moment. And Baz from Health Watch.
Yeah, hiya. Yeah, that wasn't going to be my point, but now that you've said it, we are working on our deep dive with ambulance service as well. And that's something that maybe we'll bring back at that time in September, if that's when they're coming back in and pick that conversation up then. But again, to reiterate, in the rural areas, the Cat 2 and Cat 3s are consistently being missed on the times, just to say. But in my question more, and maybe part has been asked already by the councillors and part's been answered, is about the, that moment, freeze. Sorry, apologies. The question's gone. Sorry, I got distracted by the Westminster. Can I come back in on that in a minute?
I'm glad that happens to somebody else other than me.
That's never happened before.
Thanks, Baz. Councillor Norman.
Well, usually if you're distracted, just come back to you, so I'll help with this. But it was just a basic question I meant to ask earlier, really, which was, do you actually learn from other ICBs at all? Do you process there? We do in councils, but there's no reference here. But I just wondered, it's very basic stuff which I may ought to know about, but I don't. So I'll be grateful. That's the word. I'd be grateful if you could help me on that one.
Yes, no, absolutely. We're part of regional and national networks in terms of best practice and learning from other areas. There's often different initiatives piloted in different places that will then become adapted as national stance, if you like the new single point of access we're putting in. But as important to me is the more informal networks that we have with other areas in terms of learning from what people are doing, what they're piloting and what's worked. So I'm always keen to, particularly during the summer months, pilot new things with the hope that we can try and embed them. Yes, thank you.
Baz, second go.
Apologies. I wrote it down just in case now. Yeah, it was just to do with industrial action. It's something that we were keeping an eye on. What we do know is about 840 appointments were cancelled, or operations were cancelled. And it's not, I suppose the question is, it's not the first bit of industrial action that's happened. It could happen again. What's being done to mitigate against those missed appointments and what's going to happen if it happens again?
Okay, thank you. Yeah, certainly industrial action over the last 18 months. And I think we're well in excess of 30 periods of industrial action over an 18-month period now across different groups have been really, really challenging for us, for the whole system, from a planning, delivery and recovery perspective from them. I think we've got reasonably robust processes now that we can sort of wheel out when we're entering periods of industrial action, but that doesn't negate from the fact that it does have an impact in terms of appointments, in terms of procedures, and generally it means that the capacity that we do have remaining has to, in a way, act down or move to face ED and face emergency care. What we're always doing is prioritising those with the most time-critical treatments, so cancer patients, for example, particularly during the last period of industrial action, making sure that they were still treated within pathway times, and then also where we do have to take the unfortunate decision to cancel patients, we're trying to make sure that's not where those are the very longest waiters on our pathways as well. So it's essentially trying to make sure we're still targeting the remaining service we've got around those who need the care the most, be it from an emergency perspective or an urgent cancer perspective, or those who've been waiting the longest. It is a difficult balancing act, though, absolutely. And I have to say the system as a whole has worked really well together to plan and support during those periods of industrial action. Thanks. Okay,
thank you. I think for me, I think there is frustration, and I think two councillors have already alluded to, in terms of data not including hospitals that are adjacent to Staffordshire, that look after a number of our residents. And I think the other is recognising that we're also very much a rural county that needs that, again, performance levels, that means that our residents as a county are being looked after. I notice on your traffic light key thing that I always worry in many respects when you see these kind of things, when the items that are flagged up red and yellow are always the greater number. And obviously, for me, that needs to go the other way, that we're starting to see more green and things are on track and so forth, because it surely has an impact on the overall performance if actually, if I can use the expression, you're chasing your tails and it's actually not delivering then the service and the performance that we would like. So hopefully we'll see in future reports something that may correspond to that and of improvements. Yeah. I don't know whether you want to comment now.
Yes, no, thank you, absolutely. I mean, I think it kind of outlines the level of challenge that we do face, but you're absolutely right, turning those, particularly the ambers, because amber can be a bit of a middle ground, and you think, what's going on here? But turning those to green is vitally important, as much as the reds on there, so thank you.
Okay, I think we've done on this particular item. So I thank you for your input there, Phil, and Paul as well. So, and Tracy came in. So if we can move on to item 5, a report from the Staffordshire Stoke and ICB. Paul Brown, this is on the systems operational plan.
Yeah, thank you. Thank you very much, Chair. Yes, I'm Paul Brown. I'm the Chief Financial Officer, but I'm responsible for the ICB and the system for the system operational plans. That's why I'm here today. But I will kind of talk about my day job as well, which is the money, if that's okay. There are 5 areas I just want to pull out from the report. I won't go through it page by page, but want to just talk about how the plan was developed, how it links together to other to the strategy for the system. I'll just pull out some of the key elements of the plan, talk about the money, and then finally talk about the recovery. So 5 areas I'll quickly touch upon, if that's okay. So in terms of how the plan was developed, we are working really well as a system. And when I say system, I do mean health and social care. So working with colleagues from the County Council and the City Council. And we've had now a number of events where we come together as colleagues across the whole system to develop plans. So the plan that you see before you isn't just a creation in a dark room within the ICB. It's been created by people across the system. And yeah, I would say I think we've got further to go in terms of building in the elements of social care, but increasingly we're trying to look at this as a health and social care pathway, because, as we know, patients don't distinguish between the two really, and certainly within health, they certainly don't distinguish between primary care and secondary care and community care and mental health. We're trying to pull this together into much more of an integrated plan that covers the whole pathway. And so grateful to colleagues and this from the council, particularly Pat and Richard, who have been very active in helping us get to this place. So that was the first area. The second is just to talk about the linkage of the plan to the strategy, and that's covered. You've got quite a big pack in front of you, I know. So I'll just, those who've got it open in front of you, refer you to page 30 of 98, which graphically aims to show how these things join together. So we have created a strategy, again, that was created by the Integrated Care Partnership, which is a number of partner organisations, not only health and social care, but also, for example, police and other community groups. And in that Integrated Care Partnership strategy, we've identified, we call them the 4 Ps, the 5 Ps, because they're easy to remember, but it's around people and communities, personalised care, personal responsibility, prevention, and productivity. Those are the things that the Integrated Care Partnership agreed with the things that we should work on over that strategic period. That is then taken forward in what's called the Joint Forward Plan, which is a 3-year look, and that's a document which has been written, which sets out our aims as a system over a 3-year period. And then from that will flow a series of 1-year plans, and this is one of those 1-year plans. This is the plan, obviously, for 24-25. So that's just the context. So that's the second area I wanted to cover. So on the next page of your pack 31, the third area I want to just reference you to, a graphic again that shows our collective key aims and our collective 5 key operational priorities. So it's really important to say up front the 2 key aims. The first is to provide safe, timely, sustainable care, and secondly, to meet the capacity challenge. And we put those up front because, and I'll come on to finance, but we're absolutely clear as a system that providing safe, timely, sustainable care and having capacity to meet care, the 2 things that we have to do. And I'll explain in a second how, unfortunately, that means we've got some financial gaps, but we have prioritised those things up front. And then from within that, talking in the meetings I refer to where we've developed this collectively, we've identified 5 areas where we really want to focus on the current year, and you can see them set out before you in the wheel. The first is to address and this is really very much listening to what you, others, and Health Watch colleagues have said. We do try to listen to the patient voice, and loud and clear, people are talking about the problems of access, and that's across the whole piece. That's access into primary care, into secondary care. Colleagues mentioned autism. All these services, access to those services is absolutely fundamental to what people want. So we put that up front as one of the key things that we need to address. Secondly, the thing that kind of joins all this together is primary care. So really putting that up front as an area for focus for us, and really connecting primary care. We've got Dr. Fawcett on screen, who, as you know, is a GP. I'm sure Steve can comment if you want, but putting primary care at the forefront of all this is paramount to delivering the improvements that we want to deliver. Thirdly, importantly, not just thinking short term, not just thinking about responding to you've asked questions about the pressures in A&E, quite rightly, but really thinking about the A&E queue in 5 years' time, if you like. So really that longer term piece around how can we provide a different model of care to our population so that we do find ways of avoiding that situation, finding better pathways for patients so that wherever possible they don't go into the secondary care system at all in the first place. That's what people want, that's what people say that they want, and it's clearly more sustainable as a solution. So really putting that again up front so that we aren't just purely focused on short-term issues we felt was really, really important. Fourthly, the area of the care that we're particularly focusing on, it's not to say that we're not focusing on lots of other things too, but one area where we know there is a very significant issue and indeed opportunity is care for the elderly and frail. That cohort of patients are coming into hospital too often. It's not what they want. It's not necessarily creating the fix. So really focusing in on that cohort, we think we'll do a number of things. We'll make it better for people who often are towards the end of their life. but will also mean that there's a more appropriate use of health resources for that cohort of people. And then fifthly, and particularly Richard Harling has helped us identify this as a real area to focus in on of care homes. We know that a number of people are in the care home sector where we see a number of patients being referred from care home sector into the health system, and really working with the care home sector, we believe that it will be possible to provide different pathways supporting the care homes with that care, because in the moment they have to provide clearly the care for people who perhaps are deteriorating, but helping work with the care home sector to do that. We recognise that the significant pressure the care home sector is under, and really prioritising that we think will be important. So that's the third area I wanted to touch on. The fourth is money. The financial position is extremely difficult. We have not been able to create a balanced budget. We spend getting on for 4 billion as a health system, so it's a huge amount of money. But we, as I've explained, we started by looking at the obligations we have to patients, to the requirements around access, waiting times, etc. That was where we started, and then we looked to create a financial solution on the back of that, and we felt that was the right way round rather than starting with the money. But it does mean, unfortunately, that we haven't been able to square off the money at this moment in time. I'll talk a bit later about medium term, but in the short term, that was not possible. On page 35 of your packs, we've set out the financial principles, which again, hopefully illustrate that we are looking at how to ensure that we provide safe services first and foremost. But beyond that, really working collectively as a system, we think provides opportunities that perhaps haven't always been there in the past. Again, thinking about the care pathway, working across primary care, secondary care, mental health, acute, and really seeing that 4 billion as a total health spend as opposed to seeing it as individual elements of cost. So that's really the focus of the financial plan now, is how can we live within that money in the longer term. In the shorter term, in the previous financial year, we coming out of COVID, the NHS was funded for all costs incurred by COVID effectively. So that was obviously made it easier. But coming out of COVID, the COVID funding was clawed back, and it has taken us some time to respond to that, and we're absolutely not alone. There are 42 health systems in the country. Only about 10 of those have got a financially balanced plan, and that's not to use it as an excuse, but it gives a sense of the context that the NHS nationally is under real significant financial pressure, and I think all systems have had that same effect that I've described of seeing the withdrawal of COVID money that was kind of, I suppose, effectively papering over cracks disappear, and it's taking some time to respond to that. So we made a deficit. So last year we recognised quite early in the year, to be honest, that we were not going to be able to deliver a balanced budget as a system. And during the year we agreed with the regulators that we would hit a target of 91 million deficit. That was significantly less than our run rate. Our run rate was looking towards about 145. But we agreed to make that improvement, and the regulators agreed to allow us to overspend by that amount. And we did, so we managed to hit that target, which in a sense is a success, might sound odd saying success of hitting a deficit, but it was difficult, but we were successful. One of the areas that we were successful was around continuing healthcare, where we have, and people often say, well, aren't you cost shunting? We've absolutely been clear in all that we've done around continuing healthcare. It's not about cost shunting. It's about identifying cohorts of patients who were effectively having over-prescribed care. And again, it's a symptom of COVID when the pressure was to discharge patients as opposed to getting them fixed. And it's taking a bit of time to respond to that. But we've managed to save a lot on continuing healthcare, and importantly, make it better for those people involved. It's been a real success story. That helped us get down to 91 million. So then coming into the current financial year, we had that financial pressure built up, and we were looking at deficits of significantly more than that, because again, we've used, without boring with all the details, we've used some of the stored up resources that we have from COVID to support the position, and we did that last year, and that's now gone. So it was extremely hard to stay at that sort of 91 million. We were looking at significantly worse, in fact. But the national NHS position is, as I said, extremely stretched. So through conversations with regulators, we were given allowance to overspend again, but it had to be better than last year. Last year was 91, this year is 90. So small improvement. But to deliver that will not happen without further action. So that brings me on to the fifth and last area I wanted to mention, which is recovery. And there are two parts of this. There's this year and the longer term. In terms of this year, as a system, we've identified a number of areas where we think there is potential. And again, working within that framework of providing safe care, that is a line that none of us will go below. But there are opportunities to do more with the money that we do have. And we've created 5 system collaboratives, we call them, and that narrative is because we see it very much as a collaborative of all parties, including upper tier all councils, as part of that, working on elements where we think there are opportunities to do things differently. And added to the CHC one that I mentioned, we've added contracts. So this is where, as an ICB, we have a very large number, it's about 200 contracts for all sorts of things, where we're buying services that often they're legacies of the previous CCGs. In some cases, there's fragmentation. There are opportunities to buy them, to procure those services in a different way. In some cases, in-housing them to the NHS, and then where it's a private sector provision, reducing the cost by bringing it in-house. Lots of other opportunities. So the contracts team is looking at where we can repatriate work, and in some cases that will mean bringing patient care closer back into Staffordshire, where we've seen, particularly around some of the mental health, learning disability care lines, where we're seeing patients having to go outside of county. Bringing them back in county is both clearly better for the individual and their relatives, but potentially better financially. The third area is demand management, because we, as I mentioned with frailty, we think there are a number of cases where there are opportunities to provide more care in a different way, rather than necessarily having it in the secondary care sector. And Phil answered the question about beds, and that's a prime example where the more beds you have, the more you fill. Well, that's not the solution. Just keep on staffing more and more beds in hospital cannot be the solution for our population. So looking at demand management opportunities is a third area. A fourth area, we've got the clinical senate, healthcare senate, working on clinical areas where we know we over-hospitalise, and they've identified areas where that is the case. So that's, again, positive. It will provide better care. And then the fifth and last area is what we've called enabling functions, otherwise sometimes known as back office. So some of the support functions where we think, again, by working collectively across the system, we can do better. So those are the areas of recovery. We're working on that right now. We have to get to this 90 million. It's been made very clear to us. We absolutely want to get there without it impinging on patient care. In fact, we want to make it better at the same time. That's the aim. And finally, then, in terms of the recovery area, what I've described is getting us to a deficit number, which is difficult, but is clearly not enough. We can't carry on having deficits forever. The NHS will literally run out of money. So there has to be a sustainable solution. And so a key priority for this year is working through a medium-term plan that will look at how we right-size the financial system. I mentioned the 4 billion. We don't think that's going to fundamentally increase in the next period as resources. So we have to look at how we can make that go further. More productivity, more more focus on where we do spend that money. And that's a piece of work that's really, really important for us to do. And again, very much want to do that in collaboration with councils and all groups. Health Watch, for example, where we need to make sure that the judgments we will make about the medium term are ones that we make collectively. So, Chair, I'll conclude there, and obviously very happy to take any questions.
Thank you very much, Paul. Councillor Norman.
Thank you, Chair. I don't know whether you ever want a witness along to this scrutiny committee from someone whose 100th birthday I celebrated with last Sunday, because expecting her to arrive to her birthday party in a wheelchair, because I haven't seen her for some years there, but known her for a while. She arrived on the back of a Harley Davidson. So I don't know whether that helps with the preventative and whether there's anything to be learned from that. And and she did WhatsApp afterwards, so she's into that. We got into trouble, my predecessors, for asking questions about deficits before. But I would like to ask this question. I may have been distracted by Paul's very loud socks here, which you can't see. You can't see from over there. But it was just the beginning of the deficit, where how it started, the deficit, and what figure was originally, if there's such a thing as an original figure. Although I think there is for the ICB, I suppose. And then the second question was really about the one-year plan, whether that's something that you don't really want. You want 3-year plans financially, but if you could help with those, that'd be grateful.
Yeah, thanks. Great questions, and sorry about the socks. Yeah, so those who've been around Staffordshire for a while will know that there is a long legacy of financial deficits. So the number is 300 million of legacy deficit that is sitting on our balance sheet. So that gives a sense of the fact that this isn't a problem that's just popped out of thin air. No. It's been there for some time, and as I said earlier, the COVID funding in effect masked that. And I personally think we're making progress in the sense that, it might sound an odd thing to say, but in those days when Staffordshire was making that deficit that amounted to 300 million, there were a small number of systems around the country that were. Now there are lots. So relatively, we've improved, which is good, but obviously we haven't absolutely got to the place that we need to. So there's a lot further to go. And yeah, you're absolutely right in your question. The 1 year, the longer term. So we need more time to sort this. Basically, is the thing. We probably need some capital to do that, because we need to think about, lots of things have changed since COVID. One of which is, lots of care has been provided more remotely. We've got telemedicine, we've got digital care, we've got self-care. All these things have changed, and we haven't currently got haven't had the investment in that to release the money. So it's a really good question. You're quite right. We need a longer term horizon, but the pressure's on us to do the 1 year number. So we're, as I said in the presentation, trying to do both together, but it is mighty difficult to do both together. So your question is absolutely spot on. Thank you.
Thank you, Chair. I'll email Rachel and Wes when I get home.
Thank you, Chair. Thanks for the presentation. Looking at it, looking at your 5-spoke wheel here, everything on there, nobody could argue with that. Those are all laudable aims. I'm just interested to know how practically any of it's going to be achieved. I'd be just sort of a bit of detail, really. Just take one. You say improve access to high-quality, sustainable primary care. Nobody could argue with that. But how's that going to be achieved? At the moment, people can't even get a flipping appointment. Or if they do, it takes them all morning to get one, and then they don't get it the same day. They might get it the next day. I'm just interested to know what are you going to put more GPs in? Are we going to put faster telephone systems in? How's it? Just practically, how are any of these going to be achieved? Just take that one, the primary care one.
Well, I probably will bring in Steve, because he's a GP, he can speak much better than I can on that. Well, the first thing to say on primary care, if you look at Chair, you mentioned the placemat, as we call it. A lot of primary care is green, is doing really, really well. And Yeah, so we just have to recognise it's not, there's lots of really good things going on, so that's one thing. Two is, if we've provided quite a bit of detail in the plan, if you read through the detail, it's lots of, the answer to your question is lots and lots of small steps, all with clearly identified milestones, people. That's how you achieve this sort of turnaround, isn't it? But obviously you're right. I mean, the pressures on primary care and all care are massive, and it's difficult, completely, it is. But, you know, we're trying to be clear in our planning and saying, well, these are the steps that we need to take. And as they've been really clear about what that milestone event is, who's doing it, when they're going to do it. And as I said, I point back to the outputs, which are, yes, there are problems. There are quite a few things which are red, but there are quite a few things which are green too. You know, a lot of the NHS is working, and we've got to build on that, but address the pressures. But can I, Chair, through you, bring Stephen to say a few words? Would that be helpful on screen?
I think what we need to do is think about what your response is in terms of John's query there. So could you elaborate for me? I'm not too...
Thank you. If it's okay, if I just pick up, Chair, a few bits of detail, and then Steve may want to come in. So I referenced earlier that we took an access improvement plan for primary care through to our board in May, and the central point of that plan really is around tackling that 8 a.m. rush for GP appointments, which I think we're talking about, and making sure people are directed to the right place, right person first time. So there's various care navigation, digital and enhanced telephony systems helping with that. There's a focus in that plan around estates. There's a focus around provision of safe, high-quality services. So 95% of our practices are rated as good or outstanding by CQC. So having robust action plans in place for the remaining 5% and ensuring that the 95% remain in a good place is absolutely important, something the board needs to be cited on going forward. And then it's essentially that collaboration piece, really, working across primary care, connecting it with other partners. Obviously, pharmacy is a key one, and as we develop integrated neighbourhood teams, having a more integrated local offer there, essentially. So that's a little bit more detail on primary care, but I don't know if Steve would want to come in as well to give a GP perspective.
If I just may, in terms of primary care, we have that as an item coming forward. So I think we need to look at that in detail in January. In January. So I think rather than getting hung up on it today, but it will be discussed.
Thank you, Chair. I'll back off on this. Can I just say, I think you're right. I think the NHS fundamentally works. I think if you're proper poorly, and assuming you can get to hospital, which is that's not always the case these days, the wheels turn and you get sorted out. Absolutely no issues with that at all. I think that's absolutely a fact. But fundamentally with the GPs, is the problem, is the answer not more GPs? And that's not going to be fixed quickly, is it? I'll shut up now, Chair. Thank you.
Okay. Dr. Stephen Fawcett, you wanted to come in.
Yeah, just to say, just in response to that last comment, I don't think GPs are purely the issue. There are a lot of different roles now in primary care that we're looking to expand and develop who can do a lot of work that GPs do. Obviously, when he comes back in January, I'm sure Paul Emerson-Jones and others will explain the whole vast range of different people, from pharmacists, physios, urgent care practitioners, and others who are now expanding the workforce, which is why I think Phil's been able to give you a list of ways that we are improving access, but there is still a way to travel. I mean, I don't think we'd argue against that, but it's continuously improving, and there's continuous efforts to improve access for patients.
Thank you for that. I've now got Anne Angela.
Thank you very much, and thank you for your presentation. I mean, I'm talking money here and talking about the elderly and care homes. I mean, all right, many years ago, doctors used to go around to people's homes, their actual, you know, where they resided, and ask them, are you okay and everything. I just wondered if there's any mileage into somebody going into care homes. I don't know whether it happens, please tell me correct me if I'm wrong, about people got a doctor or whatever, or somebody that's got some training and that, going into care homes and just saying to people, you know, are you okay? Is there anything? Prevention's better than cure. And all I'm thinking is preventing people going into hospital, and would that save money? That's where I'm coming from, the talking money side of it. But I just wondered what your thoughts were on that. Thank you.
Yeah, Steve may want to come in. I completely agree is the answer. We already have primary care support into the care homes. I think what we're looking at the moment is joining that more closely with the care of the elderly in the hospitals, because it's about providing the in-the-moment support to a care home, particularly because that's when things potentially go wrong, when individuals, where care homes feel that an individual needs some additional care. That's the moment when sometimes they often dial 999 and the patient then goes into hospital, and that isn't always what is best for the patient, but that in the moment that's what's happening. So we're working, you're right, basically. That's exactly the model we're looking at, is more care, more support going to care homes to help them manage their patients during that sort of 24-hour period.
Yeah.
Okay.
And thank you very much for the report. I'll make just two general comments, which is actually the NHS is quite lucky in the fact that you get bailed out financially. Local authorities don't. And we have to take very difficult, tough decisions. I'm a great believer that whether you're in the public sector or the private sector, shortage of finance is the mother of invention. It actually forces you to think creatively and imaginatively and solve solutions. If people keep chipping more and more money at you, actually, we're all human. Been there, done that. You don't tend to make those difficult decisions. And I think I was heartened by the new Secretary of State, Wes Streeting, in the fact that he's of the view that money isn't necessarily the solution. I think one of the problems that the NHS suffers from, and we do as a society, is that we have become so risk averse. Whether it's the fact that I'm moaning about the procedures we have to go through with traffic lights and all sorts of things with the minor roadworks or pothole repair, which costs the taxpayer a lot of money, or it's the fact that, if in doubt, secondary care is the catch-all for whether it's social care, whether it's care homes, whether it's society as a general. We're risk averse or into hospital, then it's their responsibility, not ours. And I think within social care, we've worked really hard at building up that personal reliance, self-reliance, and that personal resilience. And I think that's something we all have that responsibility. And I think, unfortunately, you know, I've worked in hospitals, they end up being the backstop. And until we have a complete change of mind, that will always be the case. I know within primary care, a lot of work has been done with social prescribing to demedicalise some of the conditions that people present with, where actually social interaction, activity within the community actually prevents people from going down the route of antidepressants. So I think we do tend to over-radicalise, and I think, you know, you're suffering from, I think since the war, people have become more and more dependent because the system's there. Pre-Second World War, you had to get on with it. And I'm afraid it's a societal thing. One question I would ask, which is a bit of a detailed one, on page 41 of our papers, I'm not sure, it's headed eliminate delays in access to treatment and long waits for care. You've got a section with in hospital we will, and as has been said, you can't argue with any of those key pieces. On your previous report, this is talking about sweating your assets. Your hospital theatre utilisation is not where it should be. It says it's not hit the target of 85%. I'm not sure quite where it is. But actually, if you want to achieve what you want to achieve in terms of reducing the backlog, utilisation of your theatres, i.e. sweating your assets, has got to be a key thing. And that's not in there. Why? Because that wouldn't necessarily cost you all that much.
Yeah, so I think there is reference in there, but it's probably in NHS code, to be honest. So where we talk about GIRFT, which is the getting it right first time, how's that for an acronym, team. So we've had Professor Tim Briggs, who's a national expert in theatre utilisation. He's come and he's done an awful lot of work, him and his team, with our theatre teams locally to improve that utilisation. So utilisation at the moment is in the 70s. On average, it varies per theatre. And clearly, from a productivity perspective, you're absolutely right. We've got to sweat those assets to the max and make sure we're getting towards that 85%. The other part of this is the development of sort of dedicated theatre areas. So we've had, for example, a new hand unit in Stafford, so a dedicated area that just does one thing over and over and over. You get more efficient then than if you're doing a hip in the morning, or whatever in the afternoon, and something else in the evening. You have to change the theatre around. So trying to run theatres in a dedicated way, so you're doing a lot of the same thing, also helps with that productivity piece. And productivity is absolutely central to what we need to do in terms of financial recovery, productivity and backlogs. Thanks.
So can I call Councillor Sylvester Hall, please?
Brilliant. Thanks, Chair. I was hoping I was next because one of my questions comes nicely onto the back of that. As a county councillor and a district councillor that covers Lichfield district predominantly, when I see reference to the George Bryan Centre, I always pay particular keen interest. But specifically on assets, and you might see that there's probably a little bit of cynicism in the next part. On page 54, we've got identifying sites that we're going to be underutilised for sale, and that there's been a modest amount of return from selling off some of the sites previously, and that's anticipated to be ramped up during the next year. I think we've got 1.9 million as a figure that's been identified. Now, I fully appreciate when you've got a deficit of 91 million, that's not exactly going to help. But when you've sold off those assets, they've gone. From my perspective, is looking at how do we balance being able to have that locality provision, potentially when some of those underutilised assets are being sold off. So how are those sites identified? Are you looking at making that something that you want to increase on in future? When we look at selling assets to hopefully bring some much needed return in to offset that deficit.
Yeah, thank you. So in terms of George Bryant and other sort of the community sites, those are central to our plans, building services from those hubs. That reference is about that in many of our communities we have duplicate facilities that are often between health and local authorities actually, but certainly between health partners, between primary care, between with the community. So what the vision that we have is yes, to frankly, yes, reduce the number of buildings that we have, but absolutely not to reduce the hubs, but actually to concentrate services in those facilities, and then that will allow us to, and it depends on the location. I mean, you mentioned Lichfield, it depends on the location clearly about what you need, where you need it. It will be on a case-by-case basis, but certainly there are a number of places where we've got multiple buildings between health and local authorities that potentially could be consolidated into one to do, as you say, to release capital and to release revenue. That's what that's referring to.
Yeah, so I think for me, it's looking at how those sites are identified. You know, is it purely down to the fact that nobody's using them, or is it something that they are more actually a valuable asset that could be realised into a lot of capital?
So it's absolutely about the utilisation, and there aren't many. I don't found a single building yet that's not utilised at all. Just that you've seen that the percentage utilisation has fallen in most of our buildings, particularly since COVID. So it's based on utilisation, and then the question is, well, if the utilisation is, yeah, if it was as beautiful as this, would be easy, wouldn't it? 50% here, 50% there. Well, let's put it all into one. It's that sort of logic. But to answer your question, absolutely driven by utilisation, not by capital value.
And then if I could just come back for an unrelated comment, I was really pleased to see that women's health is identified in one of the features in this particular report. As the chair of the Women's Health Working Group here, working with Dr. Clarkson, I found it extremely helpful to be able to get some of that insightful information. We focused on endometriosis at the moment and primary care network, but when you see the statistics that say that women can be waiting over 7 or 8 years and can have appointments into double figures, that you can see where there's much opportunity for improvement on the provider's point of view, cost saving potentially, but equally from the resident point of view. So thank you for that.
Thank you, Chair. Thanks for the report. It's good to see measurable targets and milestones, but, you know, there was going to be a but. We've had deficits in the system going back at least 10 years. So, and every time the various organisations in management roles have said we're going to get rid of the deficit and it's going to be sorted, and it never is. So what is different this time? You know, okay, you've got the paper, you've got the measurable targets, but you've still got to meet them. So what is different this time that you're going to get rid of the £90 million deficit? Okay, that's smaller than the previous deficits we've had. So what is the significant difference which is going to make it different this time?
We hope the collective working that I mentioned. You know, I think if you look back in time, when it was before I joined Staffordshire, but Staffordshire, I worked in London, and I'd heard of Staffordshire because of bad relationships. I think we had definitely moved on from that. We've got good relationships. And I wish I could sit here and say it's going to be easy. I definitely won't do that. But I think we've got a chance now because we're working in a different way. We're working collectively. We're looking at that full $4 billion that we spend. That has to be the solution to do this together.
Well, clearly, one of the solutions is getting primary care right, because, of course, it's far less expensive to treat people at primary care level than to admit them into hospital. Now, earlier on, we were talking about discharges, and on page 36 of your paper, you have discharge. There has been pressure in discharging people from hospital, and although we have made some progress in recent months, there is still further to go. Many are not discharged on a timely basis. That's not what you said earlier. And as a system, we discharge more people into bed-based care rather than getting them home. So what is the issue there? It seems you were saying that earlier that people are discharged on day 1 or day 2, or if worst, day 3. This doesn't seem to be saying that.
So there's 2 points to that. So certainly, I mean, that there will be bits of variation and we can always do better, but as a general rule, the timeliness of discharge is very good. I think that the challenge within our plan is about the setting of discharge to and the support that people are being discharged with. When you compare us to nationally, we have higher proportions of people being discharged with ongoing support and higher proportions of people needing on long-term bed-based or community-based care than in other areas. So I think the focus is about the right kind of discharge with the right support, but support that enables long-term reablement and independence and doesn't sort of create a long-term dependency, if you like, on the system. So it's kind of maximising those outcomes. So it's more about the discharge route, if you like, and making sure that people are going on a pathway that gives them what they need to regain their independence, rather than about the timeliness. Thanks.
So why aren't we getting that right? Why aren't we being able to get people discharged to home rather than bed-based care? Because that's presumably what Councillor Jess was talking about earlier, is that with social care support, then people can be independent at home.
Yes, absolutely. And I think, as I alluded to earlier, once particularly the very elderly are admitted to hospital, there's some statistics Steve will be able to help me out with in terms of deconditioning around muscle mass, and essentially once people go into hospital, they'll come out in a generally worse position in terms of independence, in terms of their own sort of strength and muscle mass, etc. So the challenge really is to prevent unnecessary admission in the first place and ensure that people are getting access to the care that they need before it escalates to being an acute need, and therefore you've got less of a journey in terms of re-abling that person and getting them back to independence. But I don't know, Steve, if you just want to add to that from a clinical perspective.
Yeah, no, I think you've covered it off, Phil. The statistics on loss of capability after even 72 hours in a hospital bed is pretty remarkable. And their inability to do activities of daily living and regaining their original status is absolutely known. And I think the other bit, just to concentrate on, is we're also looking at people's journeys whilst they're in an inpatient bed to make sure that they have the shortest journey in that bed. So both the pre-hospital and the journey through the hospital bed itself is really key to making sure they can get back to where they need to go. Both are important, I think, but the pre-hospital does seem like the area that we can get the most effective gain.
So what are you doing to resolve that?
From a pre-hospital perspective, so we've got a demand management system collaborative, it's termed, but the focus of that is very much around ensuring that people can access the care that they need before escalating to the point of needing to go into hospital. So things like when we talked about care homes, having an enhanced care home intensive support team who can go in and support and prevent that escalation towards conveyance. Our virtual wards that we have, community 2-hour response that we have. It's all about making sure you can get to people in a timely way, preventing that escalation in the first place and managing as much as possible within the local home environment or as close to home as possible. Essentially, as Steve says, once you become an inpatient in the hospital, that carries with it another sort of set of challenges and risks in terms of long-term. And just lastly on that, I think an important thing that we are doing, setting up this single point of access for care professionals from September onwards. We have a very fragmented system in terms of there's many different offers in different localities. So having something, for example, that an ambulance crew can phone and say, actually, I've got a patient here who's fallen and needs X, Y, and Z support, we can ensure that the right team is going out to that patient in the first place, which will prevent a conveyance to hospital. It's similar with the care homes and with other areas, but it's all about preventing that escalation to hospital in the first place, really. Thank you.
Thank you. Kath Parry.
Thank you, and thank you for the presentations. Just a couple of quick ones, actually. There's a lot in this planning document that you've just presented to us. Lots of words, lots of planning. How are you going to relay that to the user of the services that you provide? It's difficult for them to understand, to get across. When they go, they automatically assume something's going to happen, but then there's a change in some of this. And is it all deliverable? I'm assuming you're hoping it is on that one. And particularly with the partners and care homes, etc., you know, there's a big pull on them as well. And other services that are in this document. I just wondered if you could just explain a little bit how you're going to get all of these words that are in here to the people that actually use, the public out there. It's because that's what it's intended to serve at the end of the day. Thank you.
Great question. I'll perhaps go to Tracy for the point about the communication and talking to patients. In terms of the question you asked about, is it all deliverable? Well, yes, but you know, the but is there is a huge amount of risk. You know, in this, both in terms of finance, but that obviously spills out into delivery. We haven't got the resources to, increase our workforce, for example. So it's difficult. I'm sure you know it's difficult. So yes, it's deliverable, but it's not without risk, will be my answer to that question. But in terms of the comms piece with the community, Tracy?
Thank you. Thank you for the question. So they don't need to see all this, do they? You know, people need to understand what bit of care they need to access, and we need to simplify that. So there's a lot of words on a page here, and I think this is our commitment. And yes, we can write that in a much more easily accessible way, that this is our commitment. But I think the important thing for people is they feel it. And actually, when we go out to talk about, we're going to move on to urgent and emergency care and what the communication and engagement plan is with that. Anytime we're going out to talk to the public, it's an educational piece as well, because there's stuff around here with population health management, things that people can do for themselves, but it's not actually saying how you're getting the plan out there to them, because that's the plan, but actually it's actually how are we going to deliver this care? How's it going to feel different at general practice? We've done some engagement around, you'll have seen it last year, possibly. You may get to talk to a paramedic, you may be talking to a pharmacist, you may be talking to a physio. So it's actually all about those pathways rather than, you know, the overall plan is there available publicly, but actually I think it's more important, and the feedback I hear from the public is, well, how does it impact on me? How do I do things different? How do I get that care? How do I get that access? And I think that's what's important for the public to hear. And we do that on a continual basis, but like you say, you'll hear in a minute about how we're going to talk to people about urgent and emergency care. So we would be doing that on all of the pathways that are in there.
Sorry, and on the care homes?
Yeah, I think the care homes, I mean, there's a lot of work going on around the care homes, and I'm a nurse myself, so I recognise the need with care homes, and I think that enhanced team to help people make the right decisions, it's really hard, isn't it, that it's at night, someone's fallen, they need to make a decision. Having someone to contact that can give you advice and help actually is a big thing. So you know, working on what people need, you know, what the carers in the care homes, you know, whether it's residential care, you've got nursing, obviously in the nursing homes, but actually just getting that voice that's giving you the professional advice on the end of the phone, or somebody who can come in, actually helps you make a different decision. So, you know, it's within the pack, and you can see each of them, what we're going to do. But again, it's sort of like understanding what's the need for them that will actually say, I can make the right decision to keep people here.
Okay, so I think we have come to the end of that debate. I think there's a lot to be taken in there, and we obviously something that's I think is concern that needs to be addressed, but we'll see what happens, I suppose, from your point of view coming forward. If I can move on to item 6, that's the urgent emergency care strategy and lessons learned from Winter Urgent Treatment Centre designation. Over to you, Phil.
Thank you, Chair. So, as you say, this report seeks to do 3 things, essentially. Firstly, provide an overview from in terms of the management and learning from surge, with a particular focus on winter. Key messages of our UEC Urgent Emergency Care Strategy, and then Helen Slater, our Associate Director for Transformation, will talk through some of the communications activity relating to urgent treatment centres that we have planned. So I think, as Paul referred to in his report, really, we've seen a great deal of change over the last couple of years in terms of how partners have worked together. I've certainly seen it since coming to post in 2022 in terms of the planning, execution and response to surge. As part of this cycle each year, it's really key for us that we do learning. So we have a learning event each April, which reflects on the whole of the last 12 months, really, in terms of surge, particular focus around winter. We did it slightly differently this year. Last year was a more technical one, but this year we had it externally facilitated, which I think helped add a layer of depth, really, to the discussions that we had. On the face of it, you could look at a couple of performance indicators, and taking your point around generalisation, you could say, well, emergency department performance has improved 6% over the year. We've got a 10% reduction in terms of the length of time people are staying in the emergency department. Category 2 response times for ambulances have improved significantly year to year. But that only tells us a little piece of the story. There is absolutely no room for complacency here, because where you compare the ground conditions from this last winter to the one before, they were definitely more favourable. Although we did have many periods of industrial action that we had to deal with as well. So it's important that we get into the detail here and understand what's worked well, what hasn't worked well, and what we can improve on as we go forward. There's a lot of detail in the report around the learning, but the key things for me are firstly the relationships have matured in the system. You may have heard us talk previously around our leadership behavioural compact, which is essentially how we work, how we relate to each other, and that is absolutely central. That doesn't mean that people can't disagree, because it's actually very healthy to have disagreement, and certainly within our learning event there were differing points of view around how we managed certain elements and how we responded to certain elements. But if that debate can be done in a constructive and appropriate way, then it is far more positive. We had a single system plan, so previously each NHS organisation has taken an individual plan to their own individual board. We've had a single plan this year, which is based on a single view of the demand that we expect to see over winter. So that has been very, very helpful. We've also had in place now for over 12 months our system control centre. This is something that reports through to the ICB, but it works 7 days a week. It works 12 hours a day, and its job is to monitor flow and demand throughout our system, through all the different agencies, and work with partners to ensure we're using all of our capacity to best effect. We've got a really good IT system that supports this with live feeds. So, for example, at any point in time, you can see how many people are waiting for an ambulance, how many people are waiting in an emergency department. You can see how many people are waiting for discharge. You can look at all kinds of information through there. So that is a really valuable information in terms of the tactical management. As I've said, we try and look at whole year in terms of surge, because it's that pattern that it's not just December and January that are busy. We have surge demand throughout the year. We've certainly improved in terms of how we manage and respond and de-escalate from periods of escalation. We do it in a far more calm and structured way than we have done previously. We've improved in terms of workforce around mutual aid. So, for example, over the winter period, we had a specific time where we were struggling with the urgent community response, the 2-hour community response, and we were able to move workforce from another less pressurised part of the system into that area so we could still maintain that response. Creativity is always something I'm really interested in here. I referred earlier to the fire service. For example, they've done absolutely amazing work for us over the last winter. 1,400 falls they've responded to. They've led a supported discharge scheme which was up and running from December, which is essentially somewhere between people who are able to be what we call a pathway naught, so patients who are able to discharge themselves home or go just with transport, versus those who discharge with ongoing support need. Essentially, the fire service do a conveyance back home, but then they do a bit of a settling in service, make sure that people have got supplies in the house, do a little bit of a safety check, just make sure that they're settled in before leaving them. They've supported 900 people to be discharged. Very personal family experience of that, and my elderly relative was very pleased to have 2 firemen taking her home, and the support that they provided to her, ensuring she had shopping, etc., was really, really valuable. So as we move forward, that focus on that creativity, the role of other agencies, the VCSE as well, in terms of what can be offered there to support, because often it's not the very technical support that people need, it is just that softer support in terms of being able to manage and get themselves back on their feet. We've certainly improved in terms of how we approach risk share and risk management, and when I talk about that, I mean clinical risk management within our system. So I talked earlier about how the greatest risk is always the patient who's lying on the floor waiting for an ambulance at home because they've had no form of assessment, you don't know what's sort of waiting there versus patients who are, albeit not necessarily in ideal care settings, but who have got some form of support. So we've absolutely got to ensure that at times of pressure, we're diverting our resource and capacity to those at greatest risk. And if necessary, Steve can take us through a bit more on that. And then the last point is one I referenced earlier, which is around that early warning, where you look at patterns of data, patterns of business intelligence reports that we have. Often it's possible to predict where these periods of surge are coming, so we need to get better on the front foot of that and being able to proactively make steps so that we're not in a period, so that we don't end up in significant escalation. So that's winter and surge in a nutshell. I mean, I think a thread of the conversation today really has been around the level of challenge facing our urgent emergency care services. We know we've got the growing demand, we know we've got population changes, we know workforce is a challenge, we know resources are a challenge. Added to that, we've got quite a complex tapestry of services and offers within our system. People have told us that it's not always clear what's the most appropriate service to use, and that leads to people accessing emergency departments with perhaps more minor conditions, because often emergency departments are the fixed point within our system that people will use to access, but it adds pressure to those emergency departments by having people there who could be treated in other settings. So essentially we want to tackle these challenges through our strategy and make sure that people are receiving care in the right place at the right time and get the right treatment. So to do this, the key areas are, if you like, to ensure that we've got a simplified, consistent and timely offer, making sure that any urgent and emergency care that's delivered in hospital, it has to be within a hospital setting, and look at other settings to support lower acuity care, to make sure we've got the right advice and signposting for care, and to ensure that people are receiving care in a place that best meets their needs and outcomes for both their physical and mental health. So at this point, I'll just hand over to Helen to take us through some of the communications and engagement work that we're doing around this urgent emergency care programme. Thanks.
Thank you. We're joined by Dr. Steve Fawcett, who will be able to answer some of the clinical questions as well. So a number of you will be aware that we started looking at the urgent and emergency care services prior to COVID and reviewed services at each of the emergency care portals across Staffordshire and Stoke-on-Trent. We paused that work due to COVID, and in autumn of 2022 we undertook some engagement activity to understand how people had accessed services across the system during COVID, and to look at the clinical model of care that we wanted to take forward. That model of care was shaped by the draft Urgent Treatment Centre strategy and principles that was set out by NHS England at the time. That specification has changed 3 times since we undertook that piece of work, and we've now received the final specification. So over the last 12 months, we've worked with each of our service providers to review those portals again, to look at our emergency departments, to look at our walk-in centres and minor injuries units, also working with our primary care networks in terms of the impact of the Fuller report to look at that same-day urgent care offer. And we've identified through the specification how we can enhance some of our service provision to meet the UTC specification, but also some of the challenges that we face in some of our portals as well. So over the summer, what we would like to do is to hold a series of communication and engagement events. We're looking to undertake a number of drop-in sessions and focus groups, locality meetings, online survey, so that we can build upon the work that Health Watch have undertaken in terms of the ambulance service, and to understand further in terms of the impact. So we recognise some of that information will link through to primary care, it will link through to care, self-care, which we've talked about, and people taking responsibility. It will also provide us with an opportunity to update in terms of some of the services that are out there for people to access prior to calling 111, such as the new Pharmacy First services. So this piece of work will be partly communication in terms of an education piece, helping people to understand how they can navigate some of the urgent and emergency care portals, services themselves, but also how to access services in a timely way. So it comes back to that strategy piece. So we're looking to launch the communications and engagement work from the 29th of July for 10 weeks. And what we would look to do is to come back to you in the autumn with the feedback from that engagement work, but we will also use that engagement outputs in terms of developing our proposals for our urgent treatment centres. In the meantime, while that work is ongoing, we are working very closely with NHS England in terms of the designation process and the assessment of our sites. And we're having site visits next week from NHS England so that they can assess in terms of where we are against those specifications. We recognise that there's still a long way to go with this piece of work, but we want to make sure that we are developing urgent treatment centres and the wider urgent emergency care offer that is appropriate for our local communities, and part of that is making sure that we're engaging with our communities through this process.
Thank you very much for that report. I think just before I invite Phil Hewitt and Charlotte Atkins, can you just, in terms of the most appropriate time, to bring the systems pressures to the committee? Currently we have it in September on our work programme, but perhaps it should go in December, giving you the real information that's going to come from it. Would you?
Yeah, thank you, Chair. I mean, I'd welcome that, really. So we start the sort of governance route, and we begin that with Clinical Senate during September in terms of a surge plan, and then we lock down that plan in November. So I think it may be more helpful, but happy to come at any point, but helpful to come once that plan's locked down, and then we can talk through exactly what we are doing over the winter period. So I'm happy to work with your timescales.
Okay, well, we'll take that forward onto the work programme, but I just wanted to be sure if September we might not really have the information. I think that's what you're saying.
Yes, yeah, absolutely. So we'll still be in the development phase of the plan there. Certainly we'd be able to give an update in terms of where we're at, but in terms of a finished product, if you like, that would be at the end of November.
Thank you. Chairman of Council, Phil Hewitt.
Oh, thank you. And thank you for the report, which I read with real interest. I have some challenges. Firstly, please, this is meant as a compliment, that we keep trying to stop the winter issues and the winter challenges. And in my many years in this world, and you can say I'm not a young man, we never really succeed, do we? But that's not meant as a criticism. That's meant as a let's keep doing our best on this, because the winter challenges are huge. And we'll turn on BBC in December and there'll be a reporter in an A&E, won't there? And they'll all be there saying, you know, we haven't cracked it again. So compliments that we have a go, and there's a real recognition of. So I think you listed the problems, not necessarily listed the solutions. I'm going to come to my point in a second, if you'll bear with me, Chairman. I love the way we're thinking differently, that we're thinking about using firemen and such case. Like us all, I have an incident where that worked from somebody, and it's great. But from a personal point of view, and often with health, you have to refer to a personal point of view, because I don't know the technical. I don't know it technically well enough to discuss the the bits about it. But the thing I'm concerned about mostly is I come from Cannock Chase, and we had a really thriving MIU unit. So you, right at the end of your conversation, you talked. It's Phil, isn't it? You talked about entering the system in different ways, to look at different activities, the way we do it. So we had a thriving MIU unit. It genuinely upsets me that in all of Cannock Chase, we can't enter a system where we have minor injuries, or we have anywhere. You know, if you can tell me there is one, that's great. So, for instance, I had an issue, I had a health issue, I broke my leg and ended up at Lichfield, at the MRU unit, well treated. And I have ongoing issues from that, and I'm still at Burton-on-Trent now because that's where I was referred. I'm really lucky. I can drive, I have a lovely wife, I have family that look after my needs at the time. So it's great. But and the real big challenge is in this chamber, Mr. Chairman, I was promised that it would be open. And I know I was given a date when it would be open, and that really, really saddens me. Because not only that devalues this chamber, and it devalues this scrutiny meeting, Mr. Chairman, because that's what happened. So I'm speaking for the people of Cannock Chase and say, it's not fair, it's not right. You do this report, and it genuinely upsets me that you have all these ideas, and not one part of it says that the people of Cannock Chase can have an MRU unit, and it's not acceptable, Mr. Chairman. Absolutely not acceptable, and it never will be as far as I'm concerned. Excuse me for my harshness. I tried to start with a compliment, but I really, thank you.
Thank you, Councillor Hewitt. Would you like to come back on that?
Yeah, so there's been a process that we've gone through. So in terms of the MIU, as it was when it closed prior to COVID, we recognised that there were some challenges in terms of the delivery of that service, and recognised that certain elements of it meant that even if you turned up at the MIU, you still had to go to other services. We've reviewed the activity that went through there and looked at that in terms of what should be seen within primary care, what should be seen within what would be a UTC, and what should be seen within an emergency department. We've got ongoing conversations with the local primary care network. We did at one point, I think it was 2021 or 2022, where we did go out for a procurement process for the minor injuries unit. But our stumbling block on that was having the available clinical space to deliver that service. So the clinical strategy from Royal Wolverhampton Trust is to not have an MIU or an urgent treatment centre within Cannock Chase Hospital. So we went through a process of having to close that procurement process down and to look at seeking alternative estates. Now that we haven't been able to resolve that issue, and that is why the service has remained temporarily closed. But we also need to make sure that with the UTC specification that we're putting the UTCs in the right place, and that's why we're still working through this process, and we want to understand of those patients. So we know that a large proportion of patients have gone to Samuel Johnson, to Royal Wolverhampton, to Walsall and to County Hospital, and we want to understand through these conversations over the summer with the public and with other stakeholders and the primary care network in terms of what is the appropriate service for Cannock and the rest of Staffordshire and Stoke-on-Trent. So that's why this work is still ongoing.
Thank you for the answer. I still feel really passionate about it. I think it was closed pre-COVID, and I, honestly, it's a snail's pace, Mr. Chairman, and a snail would beat it. And I understand we've got to look at the process. It's far too long. How long does it take? You know, we are desperately in need of an MRU unit. We have this report about keeping people out of A&E and out of these areas and stop them going to Lichfield, so we end up at Burton and Derby hospitals, which is not right for where we live. It's not acceptable. It's genuinely too far. It's not too far for me, for now. But none of us are getting any younger. And I would say, Mr. Chairman, through you, this process needs speeding up. And this was my one opportunity during this to bring this up once again. And if you're coming back in October, I'd love an update and report, maybe a positive one. And thank you. Thank you. Thank you very much, Mr. Chairman. Thank you for indulging me.
Thank you, Councillor Hewitt. I just want to, before I call Councillor Atkins, I just want to remind members we've had one or two leave. I've got to make sure that we're still quorate. So I'd have to say one more could leave, but then beyond that. And I know Councillor Jessel did indicate to be before the meeting started, so I just wanted to get that as a careful of what's happening, because otherwise we're not quorate. Councillor.
They've got 15 questions later. So.
Yeah.
Yes, as you know, I did ask for permission to leave a little earlier because I've got a John Taylor Matt trustee meeting, their annual meeting at 5 o'clock. So on the basis of I'll try not to get a speeding ticket, I'll stay here as long as I possibly can. My apologies.
Okay. Councillor Atkins.
Some of us have got pretty fed up with all these consultation meetings. They've been going on for years, talking about urgent treatment centres. I've sat in many a room and talked about it for many, many years. So what I want to know is, the urgent treatment centres, clearly some will be upgraded MIUs. What will happen to those MIUs which are not designated as urgent treatment centres, first of all? Will those urgent treatment centres be spread across the county as opposed to being just at EDs? I know that you've got 3 at EDs, 3 are going to be standalone. And do we have the capital monies, to pay for this? And the other thing that you were talking about earlier was that you haven't got money to spend on staff. You're talking about 12-hour opening periods. Now, one of the reasons for the Leak MIU closing effectively at 3:30 in the afternoon, because they don't take patients after 3:30, is because of staffing issues. So you only have one shift of staff. So, are we going down yet another route, talking and talking and talking, with nothing achieved at the end of it? Because some of us have spent too many days talking about this for nothing to come out at the other end.
So in terms of the conversation over the summer, that will give us more up-to-date information from our localities, but it'll also give us that opportunity to talk through, of those sites that don't meet the UTC specification, what that potential model could look like. So within the urgent treatment centre specification, those sites could potentially be an urgent care offer linked to primary care services, community services. So it's looking at what is the appropriate service now that we've done that assessment against the UTC specification. And as I've mentioned in my introduction, is that the UTC specification has changed quite substantially since we started this work. So we've had to review and adapt, and that's why it has taken time.
Councillor Norman.
Yeah, I don't have 15 brilliant questions, but I'll just leave it to one now in case the quorum, which is just on paragraph 16, which is just the ICB has developed a robust communications and involvement plan to support an open dialogue with key stakeholders such as local MPs, councillors, patient groups, and our local health overview and scrutiny committees. A simple question really is: are you including the district council overview and scrutiny committees? Are you just talking about the Stoke and Staffordshire overview?
We've got a comprehensive stakeholder map. Sorry. No, that's fine. Sorry. Yes, so we've got a comprehensive stakeholder map that includes upper tier, lower tier in terms of, and also the opportunity through the locality meetings to bring the communities together. We will be utilising community champions to reach out to some of those protected groups that, with a name badge on, they don't want to talk to me, they want to talk to their community champions. So we've got a range of different tools and techniques to be able to make sure that we're reaching out across our population.
And Councillor Janice Sylvester-Hall.
Thank you. Yeah, I wish my colleague would have remained outside because I have every sympathy, Councillor Hewitt, for what you mentioned earlier on. But my question is looking at, for example, Samuel Johnson. I noticed that there's an expansion of some of the facilities that are being offered there. Is that requiring an investment in equipment, or is it just the extension to times that is being able to extend some of those services, for which I am very grateful, Councillor Hewitt?
So within the UTC specification, that there is an expectation that for the full operating hours, the X-ray and all the backing services are open for that full minimum 12-hour opening time. So for some of our sites, it's around not necessarily the equipment, but it's the workforce to be able to run at that full 12-hour or for 12-hour plus operating time. So partly it's the challenge in terms of workforce again, and it's making sure that we've got the appropriate technology and updating as part of our digital process, so that with services moving to urgent treatment centres, that we've got the most appropriate equipment and testing available, and that staff are trained to be able to undertake those tests, so the near patient testing, as they call it, within the specification. I just recognise that I didn't answer the question in terms of capital. So we are, as Paul mentioned in his presentation earlier, as a system we are constrained within our capital, and that's why we need to understand any of this service enhancement, what does it actually mean in terms of both a capital and revenue point of view, and that's what we're working through with each of the providers at the moment.
Thank you very much. Stephen, is there anything you wanted to add?
No, I mean, just going back to the original design principles behind the UTCs and the national specification, this is all very much about making the urgent emergency care offer more predictable for patients, because we've had a variety of different types of services which patients don't fully understand. They keep telling us that. So the UTCs is about trying to at last give them something where they go somewhere, they know what they'll get and they can predict what they need. I think the other side of this also is the huge importance of the 111 offer and using that as a signposting to get to people, because they have a very complete directory of services which can help patients. So we need to be promoting that as part of the urgent care strategy. UTC is just part of the overall community offer, an important part, but just a part of it.
Thank you there, Stephen. So I think we've concluded item 6 on the agenda, and may I take this opportunity to thank our presenters going through the questions from the members. You're quite welcome to stay for the last item on the agenda, but I wouldn't be surprised if you wanted to leave, but feel free. So quickly moving on then, before we lose any other members, 7, work programme. Councillor Norman.
Yes, just this is the opportunity just to suggest that the work programme will be easier to deal with if the scrutiny meetings were in a different place. I was actually chair of Overview and Education and Lifelong Learning Overview and Scrutiny Committee some years ago here, and the meetings then were taken in this chamber. This chamber is designed for debates. That's why you have to lean forward to get to your desk and lean back when you're listening, and obviously it does contribute to health problems in later life, I would suggest. The sound is echoey. The person on the screen there, well, I don't know whether he was guilty of anything, but he was like hardly able to see him because of the quality of that, because you've got the lights on inside and the poor. It's better when you watch it online. The seating is designed not for sitting down, but actually debates. As I say, when I was chair of Overview and Scrutiny Committee for the Education Lifelong Learning, there used to be a head teacher that used to always love standing up and going on forever. Moved into the Oak Room, and it stopped. He was okay. He actually contributed to scrutiny. And how can you actually talk to witnesses who are behind you or ask them questions in front? You've got to be able to see them. So I just leave you though, I know you have your own views, but leave you with those thoughts and wish you well in the future, wherever you hold the meetings. But
certainly, Councillor.
Thank you.
I've gone with the chamber today, simply with I think it was already out in the domain. But I'm more than happy to take it on. I have to say my hearing's not the best at the times, and I probably think that the Oak Room for me would be more conducive. So I think leave that with me and we'll take it. Councillor Jessel.
Yes, I would very much agree with that. I think the smaller room actually provides a better atmosphere to encourage discussion. With regards to the work programme, I do apologise, I do need to leave. The only thing I wondered whether it would be worthwhile, I know it's been reviewed before, but to allocate a slot for an update on this preparation for CQC, for adult social care. I think it is important that Scrutiny is aware if there, you know, any identified shortcomings, because it is an ongoing process as the intelligence from CQC inspections elsewhere get fed back to us as to make sure that we take every opportunity to make sure that we, you know, are best prepared.
Thanks for that, Julie Jessel. I don't think there's any issue with that, and perhaps we've just created a slot in September, maybe, if it's too early or not, maybe. Zach.
Sorry, Chairman, before Julie leaves, I'm just thinking, and he's committed to agree to it, but I'm just wondering whether it would be nice for us to write to the head of chief officer. Thank you. And just say thank you from this committee for the work that they've done to do. You know, I just wonder whether, and it needs the committee to agree to that.
If that is an appropriate thing to do, I don't mind involving anybody, but just want to check that it's the appropriate thing. So can I come back to on that? Because I don't really want to step into situations where we're going off the agenda. But Zach, if you'd like to confirm.
Yeah, just on the point about the CQC inspection. So there was a working group that was done last year that you're aware of, excuse me, and appendixed to the work programme is the executive response from that working group from the cabinet member. It is something that the chairman and the vice chairs are keeping an eye on with Dr. Richard Hall, and if that's something that the committee wanted to keep an eye on as well, then that's something that the committee could do if they wanted to.
Yes, Chairman, I think it is important because I think we, as an authority, need to demonstrate that Scrutiny is being proactive in this respect. I don't want to perhaps stress the point too much. We don't want any surprises. Okay, I think it's.
And I'm quite happy to go through that process. Councillor Atkins.
Say that I agree with that, and I also agree that we should move into the Oak Room as soon as possible.
I'm going to quickly, swiftly move on in terms of in your papers there on the work programme. You can see that the executive responses to the carer strategy and the for 24-29 and the adult social care enhanced assurance working group. For those of you that were on the working group for the assurance working, I'm pleased very much that all the recommendations are noted for sure. There is no, at this moment, rejection, but obviously you will see that some are just waiting for further input and consultation. But I think that working group proved to be really worked well, and it's good after a serious number of recommendations. We've not got one fully rejected at this moment in time. Members, is there anything else? I mean, we will be meeting again in a week. I do apologise for one that this was the June meeting that was deferred because of general election. So I think we could probably have further discussion if necessary at the July meeting. So on that note, I'm going to close the meeting. Oh, Councillor Edger.
I'm just sorry, Chairman, I'm just concerned about the lack of attendance, actually, and I'm just wondering what we can do about it.
I'll take that out of the meeting, and whether it's because we've moved it and it's gone in and diaries were already occupied. But I'm going to close the meeting now at 4:20, and thank you very much for your attendance and contributions, most valuable. Thank you.